Admit everyone. We're live streaming as well on YouTube, so everyone can have a chance that way too. Hello, hello. Hello, everyone. Hello, everyone. Thank you for joining. Welcome to this Friday Forum. I'm seeing that there's still people popping in. Welcome, everyone. Welcome, everyone. Glad to see your faces and glad to see that you're joining. This is the Friday Forum, the TBPPM Friday Forum, and today we will be talking about access to the many shorter new TB regimens, and particularly the access in the private healthcare sector. And we know that the new regimens can make a huge difference for many of the people that have tuberculosis, but we need to make sure that that access is available for all of them everywhere, and that's where people seek care. So we want to make sure that many of our private providers, who are often the first point of contact, that they also have access to many of the new TB treatments, or at least that they can have a clear mechanism to referring people to access to those new TB treatments. And that's why today I'm so excited that we have a great panel. And I would like to ask everyone who is in the panel, this is an open forum. Please use the chat to introduce yourself, to ask any questions. It's a free flow discussion. We have a great moderator with us who will bring your questions in to our panel. And I'm going to introduce the panel in a second. But I would like to ask you to keep yourself muted while you're not talking. And if you would like to speak, you are very welcome to just raise your hand. That makes it a little easier for us to see. And please use the chat. If you have a specific question for one of the panel members, put their name in it, or put their, that makes it easier for them to find your answers. So with that, we have an hour. And we are recording. We're also live on YouTube. I will make sure that the links will be shared. We will be recording this so anyone can look back. We will also write a report with many quotes of the points that are being brought forward today. And we will share all of that on the TBPPM platform, which you're very welcome to join if you haven't joined already. It's a free platform for anyone to connect with each other. So, and now I'm really delighted to join, to bring forward our fantastic panel. First of all, I'm delighted to introduce our moderator, David Brannigan. David Brannigan works at the Treatment Action Group and is the key driver behind the 146 campaign that you will hear more about. The 146 campaign is the campaign to get people together around getting access to the shorter TB regimens. So David will be moderating today's panel and we'll go through the questions. And before we will go through our panel with questions, we have a short introduction on the recent mid-campaign report by Madeline Nash. And Madeline Nash, I'm glad is with us today too. She works at the Johns Hopkins University, has a background in public health, and has worked in the Canadian North with First Nations communities and in research and in project management. So she brings a lot of valuable experience to the 146 campaign and has been fantastic in writing the report together. Then in our panel for discussions today, I'm delighted that we have a few private providers who have hands-on experience with shorter TB regimens. So Dr. Nancy Rose Labarete from the Philippines, she's been involved in the rolling out of the BPAL in the Philippines over the last 2 years, been involved in the operational research, and now is actively having people with MDR-TB who are in her office dealing with and getting the shorter TB regimens, so she can share experiences about the rollout and about the direct implementation. Then I am also happy that we have Mary Zamulu. She's from Kenya, and she is in Kenya, is in the district, working in the district on TB. And with that has also worked with MDR-TB patients directly. So she will be talking with her experiences from Kenya, and I'm very happy that she's with us too. And then I'm also delighted that we have 2 more people who will be talking a bit more from the programmatic aspect. So we have Angel Mubanga from Zambia, who is with us speaking. He has been involved in the rollout of the 1HP, so the preventive therapy, for the last several years. And his story on rallying the TB and the HIV community around the rollout of the 1HP is really compelling. And I'm glad that he's willing to share some of that information with us. And finally, I'm happy to let you know that we have with us Bruce Matewere from Malawi. He works in an NGO, the civil society, that has been involved in Malawi with the rollout of preventive therapy. And from his point of view, he will be also talking about the importance of bringing various stakeholders together. And so we have a big program. I'm very excited, and I'll hand over to David to moderate today's panel. Please bring your questions and your enthusiasm to this panel in the chat and raise your hand. So David, if I can hand over to you, please moderate our panel for today.
Thank you so much, Petra, for the introductions. Hello, everyone. It's a pleasure to join you today for this discussion. I'll present a little bit about the 146 by 24 campaign. So this is a campaign organized by a coalition of TB activists, affected communities, researchers, and other stakeholders, calling for the universal implementation of the shorter, safer TB regimens for prevention and treatment of drug-susceptible and drug-resistant TB as a human right. After decades of scientific progress, we can now treat TB infection in as little as 1 month, and most forms of drug-susceptible TB in just 4 months, and drug-resistant TB in just 6 months. But at the start of the campaign, very few people had access to these regimens. Next slide, please. So what does 146 by 24 mean? One is the 1 month or once weekly treatment regimens for TB prevention. And those include 1HP and 3HP and also 3HR for kids. 4 stands for the 4-month treatment regimens for drug-sensitive TB. And those include 4-HPMZ for adults and adolescents, and also 4-HRZE for kids. 6 stands for the 6-month treatment regimens for drug-resistant TB, and that's BPALM. And by 24 is by the end of 2024, which is the deadline from the campaign for having in place the staff, space, systems, and support needed to facilitate access to the shorter regimens for everyone, everywhere, as a human right. The campaign is also working to advance priority research to fill data gaps to address research exclusions, especially for children and pregnant people. Next slide. The campaign was launched in 2022, and just this March, we released our report called Getting Better Faster, and this details progress and gaps in scaling up access to the shorter, safer regimens, and also concrete recommendations for country governments and other global health actors to meet the campaign goals by the end of 2024. So I'm just putting in the chat now a link to the report. So please check it out. As mentioned, we have less than 9 months now to the campaign deadline. So there's a lot of urgent action that needs to take place. Also, we're 3.5 years out from the deadline for countries to meet funding and implementation commitments made at the 2023 United Nations High-Level Meeting on TB. So we see this report as a really important way of generating more accountability around meeting these targets. And we're looking forward to this discussion today with all the panelists to talk about how we can improve access in the private sector. I'm now happy to turn it over to Madeline Nash, who's the primary author for the report, to share more on its findings and recommendations. And I won't go through Madeline's bio again, but she's currently the Assistant Director of Policy and Engagement for Smart for TB at Johns Hopkins University. Madeline, over to you.
Thanks so much, David, and thanks, Petra, for getting us all together. It's a pleasure to be here speaking with you all about the mid-campaign report for the 146 by 24 campaign. So there's a lot of detail in the report, and I really encourage all of you to check it out just in the interest of time and really dedicating the majority of this session to discussion. I'm just going to focus on some of the key points for each of the 1, 4, and 6 regimens, and we'll provide access to the slides. So there's a lot of information on the slides, but I'm just going to try and zero in on the top line findings. We reviewed a number of data sources to compile this report, and one of the primary data sources was the Global Fund concept notes for this cycle, and looking at what countries were asking for funding to implement and using that as an indicator of scale up, in addition to other data sources like the Global Drug Facility and the World Health Organization TB report. So just jumping right in, there's a lot of reasons to be really optimistic about scale up of the 1 regimens, and I'm really excited about the number of colleagues we have on the line who have that direct experience working on this scale up in country. So our analysis of Global Fund concept notes specifically, shows that most countries have plans to implement 3HP. There's slightly less uptake of 1HP as a more expensive regimen, but overall, there's really good momentum around the 1 regimens. But in terms of priorities moving forward, we really zeroed in on this idea about needing to increase TBT coverage overall, but especially for children. And really excitingly, there's been the development of a child-friendly formulation of rifapentine that's going to make it that much easier to offer 3HP to children. And the cost of that product now makes this child-friendly option of 3HP the cheapest option for TB preventive for kids. So that's really exciting and will hopefully sort of fuel, widespread uptake of the shorter regimens for TB prevention. So compared to the 1 regimens, there's really decidedly less progress around the 4 regimens. So this slide focuses on 4-HPMZ. So this is the shorter regimen for adults and adolescents. And as part of the report, one of the goals was to commission a little bit of analysis to help change the narrative around the 4 being, too expensive, having too high a pill burden, and really try and showcase what the impact of shortening treatment for drug-susceptible TB would be. So as part of that, we had an analysis commission looking at how much time on treatment could we save by switching all eligible adults and adolescents from the 6-month regimen to the shorter regimen, 4-month regimen through 2030. And that result showed that making that switch, now through 2030 would save nearly 76 million months on TB treatment, which translates to a shocking 6.3 million years through 2030. So that, means these individuals affected by TB spending that time, 6.3 million years, living their life, spending less time in clinics, having to have less follow-up, spending less time away from friends and family and work and school and all of those important things. So just really showcasing the potential impact, on people affected by TB by making this switch. And as part of that analysis, we also looked at costs saved to people affected by TB, which we know is a global priority, included in the NTB targets about avoiding catastrophic costs for people affected by TB. And our analysis showed that, we took a selection of countries looking at India, South Africa, and the Philippines, what would be the impact of, in 2024, of switching eligible people from the 6-month to the 4-month regimen. And that analysis shows that, those eligible people would save $110 million in non-medical expenses due to the shortened duration of treatment. So saving money from things like, lost wages and having to, get to and from clinic visits. So really significant impact on the quality of life of people affected by TB. And, you know, other work that has been done also shows that with reduced drug prices, you know, this regimen can also become cost effective for health savings. So we really, in terms of priorities, need to focus on increasing demand and volumes for this regimen. And increasing demand also involves addressing acceptability. And we expect that the fixed dose combination for HPMZ will really help address some of the issues, you know, related to pill burden. So for 4-HRZE, so this is the 4-month regimen for children with non-severe disease, you know, it's an interesting one. It's really a no-brainer, right? We're talking about a regimen composed of the exact same drugs that are being used now, but with a shorter duration. So that means less burden for patients, but also less burden, less costs for programs and health systems. So we're encouraged to see, you know, some countries have plans to scale up 4-HRZE, but, you know, much more should be taking steps towards implementing this regimen that has a great potential to improve the quality of care offered for eligible children, and also for reducing, you know, strain and burden on health systems and providers. So I think the priority now is to focus on supporting countries to update their national guidelines, the pediatric diagnostic algorithms, and the things that are needed to introduce this regimen at scale. So for the, sorry, is there a question? No. Okay, I'm going to keep going. So for the 6-month regimen, so this is the 6 BPAL and BPAL-M regimens for drug-resistant TB. I think across all the 146 regimens, there is really the greatest country ambition and plans and you know, actual scale up going on for 6 BPAL-M. And you know, there's a number of reasons for this. I think this regimen has really been supported by a number of key actors like the World Health Organization with their BPALM Accelerator Group, by TB Alliance, supporting operational research, Stop TB Partnership, and a number of people have really gotten behind this regimen. And you can see, you know, the impact of that in terms of scale up. I think, you know, critically, it's also just the significant reduction in time on treatment compared to the longer regimens, and also the much more pronounced safety benefits of this regimen. So we're really encouraged to see that most countries do have plans to scale up this shorter, safer regimen for drug-resistant TB. And the graph on the right just shows the increase in procurement of pretomanid, which is a key drug in this regimen. But I think important to acknowledge here is that while scale up is happening, and you know, we can see that from the year-on-year increases in pretomanid procurement, there is still a massive gap between the number of people receiving this regimen and the number of people who could stand to benefit from the regimen, right? We're talking, if we're just looking at procurement data, you know, some 51,000 courses compared to the 175,000 people who were treated for TB last year. So that takes us through the three key regimen areas. And like David said, there's also a focus on the campaign for populations who've historically been excluded from research, and for, you know, that's namely children and pregnant people, you know, who have historically really been the last to fully realize their right to benefit from scientific progress. And that's something the campaign really wanted to address. So we're excited that a number of studies have, since the launch of the campaign, been announced to try and fill these data gaps. And I think especially exciting and important is the positive results from the NTB and BTB trials, which now provides shorter, safer all-oral regimens for children and pregnant people with multi-drug resistant TB. Diagnostics is also a cornerstone of this campaign, understanding that without a diagnosis, you know, treatment isn't possible. So the campaign is really pushing for that increase in access to rapid molecular tests, and also access to you know, drug susceptibility testing, not just for scaling up BPALM, but also for the 4-month regimen for drug susceptible TB, for HPMZ, because it's bringing that moxifloxacin, the fluoroquinolone, into the first line. drug susceptibility testing becomes a crucial component of scale up. And then the key I think section of the report is really this call to action for key stakeholders. What needs to be done in order to drive forward scale up of these regimens? I think it has to be a collective effort. We need countries increasing their investment, both high burden countries to increase domestic investment in TB programs, high income countries to increase their multilateral and bilateral funding. I think there's a key role for the World Health Organization to, promote and track uptake of these new regimens, especially the 4-HPMZ, in a similar way that they've done to 6-BPOM, funding agencies to really invest in, civil society, community-led monitoring, program quality, and funding research for neglected groups. Key role for market shaping actors. And in the report, we focus on really the market shaping that needs to happen around 4-HPMZ. And then, of course, there's always a call to industry about reducing the price of key drugs, particularly delaminid, which is a core drug for, shorter, safer, all oral treatments for children and pregnant people. And then, of course, as being pushed forward by the Time for 5 campaign, to reduce the price of diagnostics. So I really encourage all of you to check out the report. I think another really exciting element is the country case studies. And I know we have a number of colleagues on the line from the various countries that were profiled in the report as being really leaders in scaling up these shorter regimens and providing some really concrete examples, I think, for other countries as to how they can do the same. And I'm going to leave it there. And a big thank you to everyone who contributed to the report and to all the members of the 146 by 24 campaign coalition. Thanks very much. Back to you, David.
Thanks very much, Madeline, for walking us through the findings of the report. So as you can see, there's a lot of good progress that's being made, but also a long way to go to fully realize universal access to the shorter, safer regimens. So now I'd like to bring it over to the panel to start our discussion. So my first question is to Dr. Nancy of the Philippines and also Mary from Kenya. So what are you most excited about in terms of the new shorter regimens for TB treatment and prevention?
Okay, so I'd like to introduce first my facility where I am a resident physician. So my facility currently is the Sorsogon Medical Mission Group Hospital, that is a tertiary, a private hospital in the Philippines, located in southernmost part of the Luzon island of the Philippines, where I am the resident physician currently, and then has been providing TB treatment for 14 years now. And I was involved in both different operational studies for drug-resistant TB. So as a part of the operational research, who experienced several transitions of regimens from long regimens with injections to a short 6 months duration. What I am most excited is the overall significant advancement to fight against TB, which offers an improved outcome that can reduce transmission rates and better management of the drug-resistant strains. With my experience both in the operational research and during my rollout here in the country, and during the implementation of the use of the 6 months regimen, I am so enthusiastic to see my patients with good compliance because of the very reduced treatment duration, and making it more feasible for patients to complete their therapy very successfully. And also its very effectiveness and safety, which offers hope for more outcomes that is successful in patients who had previously no or had limited treatment options. And also, with the shorter regimens, this leads to, I think, a very potential cost savings, which was mentioned earlier, for both patients and the healthcare system because of the fewer medications that is required compared to the very long regimen that we had previous, that a lot of medicines that the patient could take in one day. And of course, because of the shorter regimen, the patients will go to the clinic, that is fewer clinic visits, and potentially fewer hospitalizations, of course, because of the less side effects that they could have, and all of which can reduce the economic burden that is associated with TB disease. I also believe that these shorter regimens are beneficial not only for the active TB patients but also in preventing TB infections, because it can also help to spread or to stop the spread of TB, and of course reduce the incidence of newer TB cases.
Thank you, Nancy, so much. Yeah, it's really encouraging to hear about these benefits, especially related to the cost savings from the shorter regimen, as well as the fact that there's Mary, over to you. What are you most excited about in terms of the new shorter regimens for TB treatment and prevention?
So thank you, David. Greetings all. Thank you so much for the opportunity to be part of this learning network. And in Kenya, of course, we've through the Kenya National TB Program, we're able to roll out, rather implement the short-term regimen for children through the formulation of the simplified algorithms for the pediatrics. And we are able to roll out from January this year, and so far so good. One thing I'm excited about regarding these short-term regimens is one, of course, we'll have increased or improved compliance for the children. Adherence to the medication, of course, will have to be super, and also in terms of treatment outcomes, bearing in mind the country for the past years, we've been having a treatment success rate of around 91% among the children. That is for 2022. And we are hopeful that with this short-term regimen, which we are doing the 4 months of RZE, we are able now to increase our treatment success rates to almost 98% or not even 100%. Thank you, and back to you.
Thank you, Mary. Yeah, and we highlighted Kenya's leadership on scaling up the shorter 4-month regimen for children in the report. And it's great to hear that there's a higher success rate. Wonderful. So I'd like now to move over to a question to Dr. Angel, who is the NTP manager in Zambia, and also Bruce, who is working with civil society in Malawi. So how do you make sure the people you serve are able to access these regimens, especially those seeking care in the private sector? And who do you collaborate with? And what help do you need to make these more widely available for private providers? Dr. Angel.
Thank you so much, David, and good afternoon, everyone on the call. It's a pleasure to be part of this discussion. And indeed, as David has mentioned, I'm the NTP manager for Zambia, and I happen to be excited and be happy that Zambia is one of the countries where we've almost rolled out every shorter treatment regimen, starting with the 1HP for TPTs, going to shorter treatment for children, and also going to MDR. But if I now may attend to the questions asked, how to increase access to these STR regimens available, I think one of the critical steps that we took as a program was to provide the information as a first part. Now, information goes beyond just going out to meet the communities, but it started with building consensus around accepting this shorter treatment regimen. Of course, using science and also explaining it to the lay people that they understand, to say this is really good for the country. And also the cost implication, as everyone in the presentation, I think Mary did a very good job there, trying to elaborate the benefits of actually using this regimen. So when that was built, I think the next thing that has really helped us to make this shorter treatment regimen available is the issue of ensuring that we have a stable commodity supply for this regimen. And this actually now, for it to be accessed, once we have the commodity, as a country, there is a deliberate policy where we provide our services free of charge. So all our patients, including those who are in private facilities, these commodities are made available to them at no charge. That is at making the laws acceptable and friendly to the users. Then lastly, but not the least, is actually the creation of systems that will favor both Ministry of Health implementation and also our private facilities. What do I mean? For private facilities, for example, there are MOUs that exist where we've signed with them to say they can provide these TB services within their package for free. And we support them with all the commodities, starting from screening up to the treatments. So these shorter treatment regimens are also part of that package of the MOU. And we look at also strengthening the system in terms of the commodity supply. How can they access the commodities within the system? So I think that's just a glimpse of what is happening. I can move on now to what has really worked and has made it work well is the collaboration part. What kind of people have we collaborated with for us to have this successive story? We've taken this as not a program thing, but as all the stakeholders involved has to come on board. So all these processes I've talked about, information, system creation, availability, we've involved every stakeholder. That includes the technical teams, the involved communities that are the TB survivors, civil societies, both supporting and implementing partners have been brought on board, including the media to help us with advocacy. Then lastly, what help is needed from the experience? I think one of the things that we've noted is, one is we need to have proactivity from both sides. That is from the Ministry of Health side and also from the private facility side. We need people to be able to approach each other, not to wait for the ministry to approach the private facility, but the private facility can also do the same so that they access that. So on top of that, I think legislature is one of the areas that we are actually working on, where we need to mandate all our providers to actually put TB services as part of the standard of care being provided in the private sector. So in that regard, I think a draft has been made, which is in the process of actually being implemented. And lastly, I think where we need support is actually the resource. When we talk about information dissemination, trainings that comes with these shorter treatment regimens, they require resources available. So indeed, we've been engaging different stakeholders to see that we can put in one basket the resources that can help us brought this both in the government and the private facilities. So in a nutshell, that's what I can say on this subject matter. Thank you so much.
Thank you, Dr. Angel. Yeah, it's very, you shared so many insights into how Zambia has moved forward to provide access to the shorter regimens. And it's interesting that you mentioned that there's like legislature mandating that providers provide the shorter regimens as the standard of care, including in the private sector. So Bruce, now over to you. I'll repeat the question. How do you make sure people you serve are able to access these regimens, especially those seeking care in the private sector? And who do you collaborate with? And what help do you need to make these more widely available to private providers?
All right. Thank you so much, David. I think before I go to that, I just had one addition about what I'm excited about the short regimen. I think in terms of the long-term regimens, they have side effects that people face after being treated, after effects after TB. So we worked on post-TB management on 2 projects, one with Global Fund, one with LHL International. And I think we assessed about 1,721, of which 69% had a form of impairment after TB caused by being a TB survivor. Then looking at the regimens, they say that they also reduced that. That's very exciting for us because we are a patient organization and we have a membership of over 1,200 TB survivors, of which most of them had or have after effect. So looking at these shorter regimens, I think it's very exciting to see that that is an aspect that these shorter regimens can also help in terms of. Sorry, someone kept unmuted me. Can you hear me? Are you able to hear me? All
Yes,
right,
we can hear
great.
you.
Yeah. So I think that's something that I'm excited about. Now, getting to the question about what are plans for ensuring that people we save TB patients. We're a community organization, a patient organization. So we work at the community level. So I think for us, the first thing is that raising awareness about availability of these shorter regimens in the communities that we serve. We serve in now, we're going to be working in 21 districts of the 28 in Malawi. So that's a huge area. So making sure that the people we serve are aware that there's these regimens, how they can access them and where they're available as they roll out. Malawi started, I think, the rollout in January. So it's still in the initial phases of rolling out these regimens. And I think that's something that we can play a role in. And I think in terms of now making sure that they are widely available in private institutions as well, or facilities, it's about advocating. We are very big on advocacy. We worked on advocating for post-TB management, and now it's part of the National Strategic Plan for TB. So we work with our stakeholders, Ministry of Health, National TB Program to do this. So we're lucky that we have a good relationship with the National TB Control Program. So leveraging that relationship to advocate using the voices of the former TB patients to amplify their advocacy is something that could be great, so that when these regimens are being rolled out in public facilities, they should not forget to roll out in private facilities. And I think building up on the private-public mix, PPM, that the National TB Program and MOH are implementing in Malawi, where they try to get services for TB free even in private facilities. That's something that would build on to say the shorter regimens should also be rolled out like that. So I think those are some of the areas that we can work in, leveraging those so that we have people. We know 3HP now has been rolled out. They're also rolling out the 9 months regimen for DRTB, but also there's the 6 months regimen coming in. So making sure that when these are being rolled out, they should also consider private institutions. So advocating, making sure in the advocacy, that is part of that. And also raising awareness among communities about access, that they can also access these things at private facilities. So in a nutshell, I would say that. Over to you, David.
Thanks so much, Bruce. Yeah, it's great to hear about your experience and the work being done in Malawi to advocate for access to the shorter regimens and to leverage the relationships, with the NTP, with the private sector, and to really move forward that access as well, and also to have services free in the private sector. Just to mention, in the report, we highlighted Zambia and Malawi as leaders in scaling up access to particularly the one regimens for TB prevention. And one of the themes that came out was that in both countries, civil society, affected communities, end users were consulted, were involved in the process of really guiding, what this looks like, what this should look like in the country, and that was really an important part of the success. So I'd now like to move to another question, and this is for all of the panelists. So please self-select your response. So what worries do you see in the rollout of these regimens, also amongst private providers? And how do you plan to include children in the scale up, and also pregnant people and other vulnerable groups? Dr. Nancy, would you like to respond?
Yeah. So rolling out the short-term regimens for drug-resistant TB among private providers, I think present several challenges and concerns. Of course, since this is a private sector, so we have to focus on certain areas like the awareness and the training, because I believe many private healthcare providers may not be familiar with the latest guidelines. And so good with this platform, and they will be informed. And also certain protocols for managing drug-resistant TB, including the use of short-term regimens, they are not yet familiar with this new regimen. So ensuring that they are adequately trained and updated about this regimen. So that is very crucial to their successful implementation on the private sectors. Also, another challenge and concerns during the rollout is diagnostic capacity of the private sectors. Not all private facility, unlike us, the SMMG in the Philippines is a private facility, but we do TB culture lab, the GX and everything, the diagnostic is readily available for us. But in other places, I think facilities may have limited access to the diagnostic tools for accurately diagnosing drug-resistant TB, such as GeneXpert. Not all of the facilities are readily available with GeneXpert, and also the culture and the drug susceptibility testing, also the DST. So improving the diagnostic capacity and ensuring access to this test are very essential for the identifying patients who would benefit the short-term regimen. So in the private sector, these are all very limited as of today. Even in us, good for us, because I mentioned we do have this in our facility. And also, in another challenge in the rollout of this short-term regimen would be the cost and affordability, of course, because if that will be as of today, we are supported by Global Fund, but in private settings, the cost and affordability of these diagnostics and the regimen itself, the drugs, are in place of the short-term regimens may be more expensive than the traditional, the availability of the pretomanine, the longer-term treatments posing a financial barrier also for both providers and the patients in the private sector. So also, another challenge in the private is the supply chain management. Again, the supply, the medicines are all currently in the Philippines are global funded. So the private sector can access this through the facility that is catering the drug-resistant TB, like the private sector. In our facility, we cater that. And the medication is very critical for a successful implementation for short-term regimens. So, of course, you have to check the supply chain management, and the private providers may face always a challenges in procuring and maintaining a consistent supply of drugs due to issues such as stockouts or distribution logistics. So like in the Philippines, what we do in the rollout, unfortunately, we did not have any issues in the supplies. Only for a few months, we did stock out on diagnostics, the GeneXpert test. But so far for the medications, we have a lot of supply. So that will be a challenge for everyone in the private sector to access everything, the diagnostics and the medications itself. Thank you.
Thank you, Dr. Nancy. Would anyone else like to respond? What do you see as the barriers and challenges or concerns around rolling out the regimens among private providers and also among vulnerable groups, including children and pregnant people?
Thanks,
Yeah.
David, I can add. Oh, please.
Okay,
Oh, yes. Oh, please, Mary, go ahead.
Yes, so probably I could add from what my colleague has shared. In Kenya, we have, of course, the short-term regimen has numerous benefits, but of course, we'll not mention about the challenges because, of course, we are dealing with private facilities, and one of the challenges in private facilities is the high staff turnover. Remember, the National TB program will implement so much in terms of comprehensive trainings and all that. Then now, within a given short time, this clinician moves to another facility. Now, they're in terms of patient continuity, care continuity, and follow-up or even the compliance will be affected in a way. Also, in private facilities, we tend to have extremely busy schedules. And in some of the facilities, you find that it's not easy for to have one designated clinician to work in a certain department. And you see now with TB, we need someone who is there to deal with the patients because of the confidentiality and the support. So if we miss this clinician at that given time, then also it will affect the treatment adherence and compliance of that client. And of course, when it comes to trainings, in private facilities, not every clinician or healthcare provider will get a chance to attend to the trainings, but this we mitigate it through doing the knowledge gap analysis for the facilities, being able to do maybe weekly CMEs to these facilities to make every clinician become at par in case of any chance to serve a TB patient. But in terms of supplies, for us, through the National TB Program, we have a public-private mix. Of course, TWG events happening, and we are able to leverage on the resources we have to have both private and public facilities served equally with the commodities. So we do not have a challenge in terms of commodities for the rollout. Thank you, and back to you.
Thank you, Mary. Dr. Angel, Bruce, do you have any comments around barriers, concerns around access in the private sector and for vulnerable populations?
Right. Thank you, David. Yeah, I just wanted to add on what Dr. Nancy and Mary have talked about. I think the rest, they've already mentioned, so I'm not going to that. But I think there's also a worry in terms of now the private facilities, because if you look at the priorities, it is public facilities. So rollout might delay more to the private facilities. So I think advocating more so that the rollout should be also considering the private facilities to get there. Yes, there are those challenges that Mary has also mentioned, but I think it's something that I worry about in terms of now the private facilities. And one thing that I worry about, and that was also not mentioned, is now that because these are shorter regimens, and then we as committee implementers and programmers and the national programs, we also need to stress more on the patient support and during treatment, because we would like to safeguard this regimen so that they do not become resistant, and then people adhering, making sure that we protect them from resistance. I think that's something that I worry about as well, that we need to amplify patient support. This does not mean that patient support should be lax, but more intensified so that we can safeguard these new amazing regimens. So I think I just wanted to add that. Thank you.
Thank you, Bruce. Dr. Angel?
David, it's always difficult to speak last when all the points that you had put down has been said, but just one more. I think one of the worries that we have as a country here in Zambia is that we, as I mentioned, these OTB services are provided for free, and there's an MOU. But what we notice in certain times that patients are getting charged for what is supposed to be free. So that is a worry to the program and also to the sustainability, because patients might be avoiding to access some of these medications. And indeed, they're expensive if you are paying from your pocket, as my colleagues have mentioned. So that was, I think, what I wanted to just add to what has been said. Otherwise, most of the things have been said by my colleagues. Thank you.
Yeah, thank you, Dr. Angel. And thanks everyone, for raising these issues. I think, Dr. Nancy, you flagged the issue of diagnostic capacity, which is a big one. There's also supply management, access to the medications, the costs of the regimens, and making sure that people seeking care are able to access them either for free or in the private sector as well. Training and also patient support for adherence, so important. Okay, so I think where we're at now, I'd like to just see, we've got a question specifically about TPT from the chat and from Sapna, that there has been some resistance to adopting TPT in the Indian context among private providers. And it would be nice to hear if private providers across geographies have similar concerns on prescribing them. And what are the topmost concerns or any experience? So does anyone have any advice or anything to share to Sapna around having resistance to adopting the shorter regimens for TPT among private providers? Any concerns or any advice for how that's been done in your country?
Yeah, I can answer that. In the Philippines, the problem is we do want to implement the TPT. However, the issue is the availability of the medicines. That is the number one. And the rollout of how to implement this is also another issue. And of course, the access to the medicines also. Not all facilities have readily available with their own medicines, I think.
Thank you. So I think where we're at now, I'd like to just ask all of the panelists for a final summary statement. Tell us one more thing you're going to do after this webinar to improve access to the 1, 4, and 6 regimens for all people living with TB. And also, what would you like others to do? Maybe Dr. Nancy, let's start with you.
Okay, so to improve access to treatment to all people living with TB, one thing that I would do is advocate for the integration of TB services into primary healthcare settings by ensuring that TB diagnosis and treatment are available at the community level. The individuals can access care that is closer to their homes. And of course, they reduce the barriers like the transportation cost and long wait times at the centralized facility. So we have to consider a decentralized form of treatment care. And of course, I want that a patient-centered care that should be implemented in every facility. And I would also encourage others to invest in the strengthening healthcare infrastructure, like allocate resources towards improving healthcare facilities, improve or enhance the laboratory capacity and the supply chains, also to ensure the availability of the TB diagnostics and of course the medications also at all level of the healthcare system. And of course, I would also encourage others to promote awareness and reduce the stigma that has been long overdue issue in all private practice. We have to launch public awareness campaigns and everything to educate the community about the TB. TB is a very long disease, but still the stigma is there. It never resolved. The symptoms and the importance of seeking timely treatment, I should encourage of others to do also. And then I would address also the stigma associated with TB, that other people or more people to come forward for diagnosis and care. You see, in a private, they go mostly into a private uh, um, seek consult because they don't want to go to their facility in a government because of they have the stigma. They are so scared of what people will do to them in the community because they know each other. So also I would also like to encourage others to advocate for policy change. And I want the policymakers to be involved, the government itself, work with policymakers to develop and implement and also strengthen the current policies that they have, that we do have to prioritize the TB control and ensure that the equitable access to diagnosis and treatment for all individuals, regardless of their socioeconomic status or geographic location. It might be a private patient or it might be a rural health patient. There should be no stigma about it. So TB for all treatment for a short TB treatment regimen. Thank
Wonderful.
you.
Yeah, thank you so much. So now, Mary, your 1-minute summary statement.
So mine is to encourage all of us to engage in public education awareness in terms of the activities we have in the community to reduce stigma and misinformation surrounding TB, as well as empowering the public to seek TB care in all sectors, be it public facility, be it a private facility. And also something I wish to do is to support community-based initiatives that will raise that TB awareness in order to promote early TB detection and treatment for all. In other words, I need to create demand. Thank you.
Thank you, Mary. Dr. Angel, your summary statement.
Thanks, David. I had even written it down. It's just like what my colleagues have said. It's about, I think, on advocacy. So I would want from here to definitely heighten private sector engagement and indeed increase information dissemination, especially on the different treatment options available in the country to the public. That would be my general and main objective, to raise that awareness amongst all cadres that are involved across the country. Thank you.
Thank you, Dr. Angel. So Bruce, your final summary statement.
All right. Thank you so much, David. Thank you all, the panelists. As Angel said, being the last one, it's hard because all the points have been said. I think just to echo what my fellow panelists have said, it's about advocacy at the national level, because I think in us advocating for shorter regimens, we're just looking at mostly public facilities, but now making sure that that advocacy has a new face of incorporating even private facilities, and then raising that awareness even among TB survivors that we work with and communities, so they know about these shorter regimens, and there is need for them to be found even in private facilities where they could access, because sometimes public facilities are further away than the public facilities. So building the awareness raising and merging it with advocacy so that it's a big compound. Last but not least, as Mary also said, leveraging the private-public mix that already exists in Malawi to build up how these things could be rolled out, especially the short regimens in the private facilities as well. I think it's a good approach. It's a good facility. So I think those are the three: advocacy, raising awareness, and leveraging the public-private mix. Sorry. Yes. Thank you so much. And thank you for considering me to be part of this panelist. I've learned quite a few substantial things. So this was really, really great. Thank you.
Thank you, Bruce. And thanks to all of our panelists for sharing your experience. And I've also learned a lot. And I hope our audience members have also gained a lot through this webinar. Just some final things that came out of your statements. It's important to promote awareness, do public awareness campaigns in order to better provide this patient-centered care, to do advocacy, engage and work with the civil society as well, and to raise awareness in communities, and then to really focus on engaging the private sector and public-private mix and how to make that work and be more effective to provide access to the shorter, safer regimens. So with that, I'd like to turn it back over to Petra to close us out.
Thank you all so much. Thank you, David, for moderating an excellent panel discussion. Maddie, wonderful presentation as always. To each of the panel members, I'm really grateful for you sharing in your busy schedules and for giving so many points, as David basically said, one big learning lesson for all of us. And thanks for sharing amongst each other from across the world, from the Philippines to Zambia to Kenya and to Malawi, and over to the east coast of the North America where we are. Glad to bring you all together. And for any of the participants who have been with us, thank you for talking in the chat, and please share any thoughts and feedback. We have a quick poll for you to give us some feedback that we would love to hear from you. The report and the recording, everything will be online in the upcoming week, and we would love to hear from you if you have any ideas for Friday Forum points or discussions that you'd like to take up, please let us know. And with that, I would like to say to everyone a very happy rest of the day, a very happy weekend. And we look forward to seeing you at our next forum. The next forum is going to be on the 10th of May, right before International Nurses Day. And we're going to be talking about the role of nurses, how to best equip nurses in our TB fight. We really need the nurses in all levels involved. And so that's going to be, I'm excited to bring some nurses from various sectors, private sector, public sector, those that have written books about it. We have a nice panel that we're pulling together. So join us on the 10th of May. But for now, thank you all for all the work you do on the ground, and looking forward to staying in touch. Bye-bye.